Welcome again to one of the other sessions that I'm doing. So today I'm going to talk about why you need to document your work as a pharmacist in practice. In your undergraduate program and even any other training that you do as a pharmacist, you encourage to document whatever you're doing. You can encourage to practice the good documentation practices, that is as a component of practice and as a principle that is supposed to be part of who you are as a pharmacist. And that is something that is also enforced in the 7 star pharmacist principles, among them knowing that you have to be able to document the work you do, promote best practices in terms of how you document what you do and all that. So it's a critical bit of what we do as pharmacists. Unfortunately, as much as we know it needs to be happening, we are not documenting much of what we do. And there are reasons as to why that's happening. And for me, the reason as to why I'm doing this session today is just to share why you need to be doing it and what are the key drivers of the changes that we're acknowledging. At the moment, from the previous videos that I've shared as well, and even in terms of your own observations in the market, we know there are changes. And as much as changes are happening, unless we are prepared for what's coming next, and even know what has happened in the past, we are not able to conform and do the best and make the best of these opportunities. So how then do we know what happened in the past, what's happening at the moment, and how do we envision a future without having the history of what has happened? Because that history is what documentation helps us get. So documentation is going to be it is a critical component of what we do as pharmacists, and it's going to be a critical piece of how we transform pharmacy practice. And on this account, I'm more keen about the African pharmaceutical landscape, where most of the work we do has not been documented, and even in the Kenyan context, most of what we do hasn't been documented. I remember last year, but one that was in 2020, when there was the World Pharmacist Day on 25th September celebrations. And the celebration was deemed Pharmacists Transforming Global Health. It is a good topic by itself because we know what role pharmacists play in transformation of global health, from mental health care services, sexual reproductive health, access to products, even serving communities, improving that access to the local communities, logistics in pharmaceutical supply chain. All those components of global health pharmacy practice are key in terms of achieving the successes. But on this particular occasion, one of the things that was quite glaring to me is the fact that we're talking about pharmacists transforming global health. But in reality, we don't have the data points, the data to confirm that actually we're making this transformation. There is no evidence of our work. So how then do we build a case for what we do unless we've documented what we're doing? And that is one thing that I believe it's good for us to document. And as I mentioned in the last episode, in the last video that I shared, the discussion was around looking at what project management aspects are coming in. And when we talk about project management, I mentioned different dimensions of work. Some of us will be in the community pharmacy setting, running different projects, let's say, for example, non-communicable diseases related. You're dealing with patients, and these are patients presenting with diverse variables and diverse factors that are affecting their well-being. And these factors, as much as they're changing, it is you attending to their needs. And for you to attend to their needs the best way possible, you need to be able to understand the environment where they come from, document that. The intervention that you're putting in place, and you document the same. And then further down the line, you can do a retrospective analysis of what the variables they were dealing with and the environmental factors that were playing a role in their care, and the intervention that you're putting in place, whether they are achieving positive outcomes or not, and what needs to be done better. If we don't have these data points, we are not able to optimize care in the next generation. We are not able to transfer learning from one generation to the next. And that is why, at this particular moment, we could say categorically that since 1970s, when pharmacists started being trained in the country, we've not had any book written by a pharmacist that is key on looking at what are the practice trends that's capturing what we are actually doing within the country. And without that, then it means we'll be dependent on imported insights, imported knowledge, which is good, yes, because it gives us the basis. But that basis is not contextualized to what we are practicing and what we are doing in the Kenyan context or even in the African context. So how then do we ensure there is continuous learning and sharing of knowledge and insights on what's happening in our particular markets? It can only happen when me and you, who are pharmacists practicing in our areas of work, document what we do. We think of it in terms of what are the best practices. Think of it in terms of what needs to be propagated to the next generation. What are the areas of divergence from the theoretical work that we've read from our education the theoretical practices, principles that we borrow from international communities and the global community in terms of the best practices they front. Then based on what we learn, we share our best practices, collaboratively engage and share that kind of information to the extent that we're able to generate new insights. We be innovative enough by adopting best practices and guiding that conversation. So those are some of the things that we need to look at. How are we doing it? And in terms of documentation, we need to not look at it as a responsibility. It is a responsibility, yes, because there are certain areas of practice where we work and we are required to document our work. So when we are required to document our work in these areas of practice, what difference does it make if we don't document? It makes a difference because at the end of the day, you have no evidence that you ever did what you were supposed to do. And in documentation, good documentation practices, we are told, unless it's documented, it never happened. So how do you certify that you really actually did what you're trying to explain that you did if you never documented it? So that is first principle. Let's document to ensure there's a trail, audit trail, that you did what you are saying you did. There is evidence of it, there's data to certify that you actually made that observation. Then from those observations, somebody can analyze and actually make an inference. And that inference will help us in making the next step in terms of whether it's in clinical practice, regulatory practice, industrial practice, or even in community pharmacy practice, where we are dealing with patients in the outpatient settings, the environment where we work. So those are the key things. Evidence that we did the work we're trying to say that we do. Because in all the advocacy forums and the policy engagement platforms, we are looking at what do we do? What is our contribution? But we can't talk of our contribution unless we know what that contribution is. And the only way to know what that contribution is by documenting it and having a reference point of what we've done. That is point number one. Point number two, other than documentation, I mentioned the aspect of sharing knowledge and promoting continuous learning. We have young people who are still aspiring to be pharmacists in the future. There are people who are hoping to be pharmacists. There are people who are in school being trained to be pharmacists. And even ourselves as pharmacists, as we continue practicing, there are new knowledge streams that are not already with us. For us to take advantage of these new knowledge streams, we need to be able to read from what others have done and even what we did in the early days. I can talk of an example where I did some work at Kenyatta National Hospital when I was doing my internship there. One was on neglected tropical diseases, and another was on the antimicrobial stewardship. Recently, as I was reflecting on that work and doing some studies on what a good project would look like in the antimicrobial stewardship program, I just got to realize that I had already actually contributed in a particular project. And luckily, I was part of the documenting team and developed the literature on design of an hospital antibiogram. Imagine if such kind of knowledge would come back and somebody would also adopt it, because generally, for example, when we talk about antimicrobial stewardship, not many hospitals in the country have their own antibiograms. And if they don't have these antibiograms, then it means even in their infection prevention and control and the rational use of antibiotics, it might not be pointed to the particular infections that are prevalent in these facilities, increasing the risk of failure of treatment if they are told they're using an antibiotic that has already developed, microbes have developed resistance against, or if the treatment doesn't fail, we are using the stronger antibiotics that might be putting us at more risk when actually we get to have those infections that would need them. So how do we use the lower level of antibiotics, which are effective, yes, but giving us room to ensure that we can evolve and adopt in terms of changing our therapeutic lines of defense? So those are some of the things that we need to look at. And when I talk about the therapeutic lines of defense in antibiotics, we have to look at them across the three classes. The access, that is the first class, which are easily accessible, the amoxicillins and whatnot. Then we look at the watch category, where we have the cephalosporins majorly, higher level of antibiotics. Then we have the restricted access. The restricted are the most advanced, the vancomycin and related. So what are the different levels? If you have such a documented practice where I documented antibiogram, that was a project that I did when I was in 4th year in doing my attachment. Then I went to Kenyatta National Hospital. I contributed in the antimicrobial stewardship policy document. In doing that, I was reflecting on the antibiogram and also looking at what are the best practices, covering the continuum from infection prevention and control, looking at rational use of antibiotics, engagement, sensitization, and information dissemination, and ultimately financing to ensure we have new therapies being developed, that is antimicrobials. So if you document, you can go back to it and promote knowledge sharing and ensure there's cascade of how that information can be accessed. If I never documented the work I did that was in 2018, I won't be able to access it. By not being able to access it, there's no way I could have referred to it. And even now, as I'm doing another project looking at how the search can apply, then I'm able to go to it and find a way. If I didn't, I won't be able to have that information. The same applies when we're looking at other people coming after you and they wish they could have an opportunity to learn from you. If you never documented, they'll never have that chance. And therefore, even in terms of our training and practice, we will keep reading literature that is being borrowed and we're using from the global community without contextualized evidence of what we're doing. For example, currently when we're talking about COVID-19 and vaccines, everybody's talking about clinical trials. Unfortunately, most clinical trials have not been done in Africa. And therefore, we lack data, and even the therapies that we're using, we have no clear indication on how do they act in our bodies, except for minor areas where we have data. So it is inference, looking at other people, getting the data that had been obtained from them and applying it in our local context. What if as pharmacists within our environment, we could do more of such even clinical trials and document that? That would be a win. So we need to look at how do we ensure we generate local data and make it be available for future interventions, future studies, and even to grow the profession. Another thing, by documenting your work, you have information that you're sharing with others. And it helps you build your personal brand and personal profile as a professional, as an expert in your area of practice. And it also makes you be a key thought leader and opinion leader in terms of shaping the environment where you work. By so doing, you position yourself to get jobs, yes, because ultimately we all want to be able to do a job that we are fulfilled in and we're making the best contribution. And at the end of the day, we also need to make a pay to be able to lead our lives. So how do we earn an income? By doing our work. And if you're doing your work by being competent enough at documenting and being a thought leader, a shaper of the environment, you're able to make better income by doing so. So that is one value for you as a person, as a pharmacist doing the work that you're doing, other than just shaping the environment. And ultimately, the final bit, as a pharmacist in practice, your key contribution to the profession is to give new knowledge and new insights. And that new knowledge and new insights is supposed to shape the future of practice. And shaping the future of practice is shaping the future of the profession of pharmacy. How does it happen if we don't get the data? You need to make it available, need to make the information available. And finally, as a pharmacist, your contribution is dependent on how better you are innovative. Innovativeness comes with the information that we get, and we get a way to cross-pollinate by sharing ideas. You maybe probably sharing a project that you did, another person has a different contribution to it, another different perspective and a perception on how it could have been done better. Sharing that knowledge, we are creating new ideas. Creating new ideas, we're shaping the future practice for all of us and ensuring that we make the best outcomes of what we do. And on that note, if you have any topic that you feel like we should discuss and share some insights on, please leave it in the comment section or even send it to us on email. I'll leave the email on the comment section and on the review of the video. Then let's engage through our work through Africa Pharmaceutical Network and any other platforms where you are as a pharmacist. Let's make the best of the profession and champion for a better course in service to patients, because that is what we do as professionals and pharmacists. Thank you. Meet you again in the next session.